So good afternoon. Thank you all for joining us today. My name is Heather Bradley, and I'm HepU's project director. I'm also an assistant professor of epidemiology at Georgia State University School of Public Health here in Atlanta. Today, we're really excited to share some new HepU data and interactive maps visualizing hepatitis C treatment restrictions and utilizing data from the Center for Health Law and Policy Innovation at Harvard Law School and the National Viral Hepatitis Roundtable's report on hepatitis C, the state of Medicaid access. We're also going to put the data presented in context today, which we try to do on our webinars as a rule, by discussing why policy and treatment restrictions are barriers to hepatitis C care, as well as some changes that have occurred geographically over time in these treatment restrictions. We'll talk specifically about how these treatment restrictions are harmful for people, particularly people living with substance misuse conditions, and discuss ethical and moral dilemmas surrounding treatment restriction practices. So just as a quick note, we're going to be recording this webinar and we'll be sharing it in the coming days. We know this is a really busy week and month with multiple hepatitis relevant awareness days, and many of our colleagues are of course still engaged in the COVID-19 response. So we want to make sure that the webinar is available for everyone to view when they're able. It'll be posted on our site within the next couple days. And as always, we at HepU want to thank our colleagues who are still hard at work fighting the COVID-19 pandemic and have been for a long time now. So I'd like to begin by introducing our three panelists for today. First, we have Phil Waters, who's a staff attorney at the Center for Health Law and Policy Innovation, or CHLPI, at Harvard Law School. Next, we'll hear from Dr. Adrienne Simmons, who's the Director of Programs for the National Viral Hepatitis Roundtable, or NVHR. And last, we'll hear from Dr. Lynn Taylor, who wears multiple hats. She's the Director of HIV and Viral Hepatitis Services for Kodak Behavioral Healthcare. She's also a research professor at the University of Rhode Island and is the director for Rhode Island Defeats Hepatitis C. So just a quick overview of what's a really full agenda for today. I'm going to give just a quick introduction to HepU, and then we'll get straight into our main topic, which is hepatitis C treatment restrictions. Then we'll have Phil from CHLPI give some background on his group's analysis on treatment restrictions, as well as some changes, geographic changes that have happened in treatment restrictions over time. Next, Dr. Simmons will talk about the importance of removing restrictions to care for hepatitis and some examples of how to use the data that you can find on HepU for advocacy purposes. And we'll end our webinar with a conversation between Dr. Lynn Taylor and me about moral dilemmas surrounding treatment restrictions, and also how these restrictions impact real patient lives and people who need care for hepatitis C. So we'll end the webinar with a few minutes for question and answer. You can find the Q&A button at the bottom of your screen today. And so as you have questions, just feel free to go ahead and type those in, and I'll moderate a Q&A session at the end of the webinar, sorry. So I'm going to start with just a brief overview of HepU and our topic for today. For those of you who may not have interacted with us previously, hepu.org is an online platform that visualizes data and disseminates related insights on the viral hepatitis epidemic across the US. HepU is a powered by AIDSview project and builds on some existing infrastructure from our sister site, AIDSview, which if you haven't used before, you should definitely check out. AIDSview is led by my colleague, Dr. Patrick Sullivan at Emory. So HepU is presented by Emory University's Rollins School of Public Health in partnership with Gilead Sciences, and we receive support and guidance from multiple advisory committees. Our main goal here at HepU really is to make data related to viral hepatitis widely available, easily accessible, and locally relevant to inform public health decision-making with regards to viral hepatitis. And so in the spirit of this goal, the newest data visualization that we're releasing this week includes data from CHLPI and NVHR on hepatitis C treatment restrictions. The new interactive maps will include fibrosis restrictions by year and state, of course, from 2017 to 2021, sobriety restrictions by year from 2017 to 2021, and also prescriber restrictions by year over the same years, 2017 to 2021. And so these maps will be available as comparison maps to our current hepatitis C data, and will help users to really contextualize our current data in terms of geographic differences in treatment restrictions for hepatitis C, and broadly restrictions to care and treatment. So as most of you already know, today is Hepatitis Testing Day. So we're thrilled to be joining some of our other colleagues in an event held today on Hepatitis Testing Day, and happy to report that the administration, the Biden administration, just yesterday released a proclamation encouraging Americans to join in activities to increase awareness about viral hepatitis, and to increase, of course, viral hepatitis testing. And so President Biden said, today we reaffirm our commitment to ensuring everyone knows their viral hepatitis status, has access to high quality care and treatment, and lives free from stigma and discrimination. So I know all of us in the hepatitis world were really encouraged to see that shout out from the administration yesterday. So testing, of course, is the first step toward engaging people living with hepatitis C in care and treatment. And once people know their status, they're ideally able to move along this care continuum displayed here and receive care, right, and ultimately be cured. But unfortunately, even after testing, there are still some barriers to achieving cure. And we'll be talking about some of those barriers today in the form of treatment restrictions. So last year, as most of us know, the U.S. Preventive Services Task Force expanded screening guidelines for hepatitis C, and now recommends that most adults get tested for hepatitis C, including all adults aged 18 or older, pregnant women during each pregnancy, and then anyone with ongoing risk and medical conditions, such as people who inject drugs. Unfortunately, screening recommendations don't always turn perfectly into practice, and COVID-19 has additionally had a major impact on access to and use of hepatitis C testing, as well as, of course, many other health services. Data are starting to come out now, showing the extent of this impact, but we certainly will be learning more about this impact as we go on. So one study I wanted to just highlight, published in the Journal of Primary Care and Community Health, reported that at Boston Medical Center hospital-wide, total hepatitis C testing decreased by nearly 50% just during the period between March and June of last year, and new hepatitis C patient identification decreased by 42%. And so we hope that testing will pick up again as we again, hopefully are moving toward the end of the pandemic, but it's certainly something that is concerning for many of us. So moving into the treatment access barriers for today's focus, I just want to briefly introduce the three types of treatment restrictions that we're going to discuss, and then I'll turn it over to Phil to talk about these in more detail. So the first type of restriction that we map on HepView now is the fibrosis restrictions. And so these restrictions basically require patients to wait until hepatitis C damages their liver before receiving hepatitis C treatment. Restrictions are based on stage of liver disease. And so you can view geographically mapped fibrosis restrictions, because they do differ by state, and all of these restrictions that we're going to talk about today do, as a comparison map to other hepatitis C data on the site. And what you'll need to do to look at the restrictions as a comparison map is you'll click View the Map from anywhere on the site. And then you'll first select a base data set, which could be, for example, estimated hepatitis C prevalence or mortality. And that base map will display as the left map, like what you see here. And then if you click Comparison Maps, as a drop-down, which you can see in the black bar here on the slide. You can choose to view the fibrosis restriction map or any of the other treatment restriction maps as a side-by-side comparison to the hepatitis C data on the left. So the second treatment restriction that we map now is a series of sobriety restrictions. These restrictions require individuals to abstain from using alcohol and or drugs for a specified time frame prior to them beginning hepatitis C treatment. And so again, these restrictions differ by state, but they may require individuals to be in screening and counseling for substance use, or even to abstain completely from substance use for periods between 1 and 12 months. The final restriction that we map on the site now is prescriber restrictions. And so these restrictions essentially limit the kinds of practitioners who can prescribe hepatitis C treatment. So they require patients needing treatment to be seeing a provider who's in consultation with a specialist, or to see a specialist directly to receive care. So this can make it difficult for people to get care because of the need for special referrals, additional clinic appointments, or transportation to see a different doctor. So I'll end this first portion here by just saying that, at HepView, we think it's important to get the word out about these treatment restrictions and to monitor how they're changing over time, because as most of us know, hepatitis C can lead to severe liver damage, liver cancer, and even death if not detected and treated. And so recent strategic plans, which you can see here from the Centers for Disease Control and Prevention and HHS, have specifically identified reducing hepatitis C related deaths nationally as an indicator to monitor progress toward achieving hepatitis C elimination. But barriers to hepatitis treatment, especially among vulnerable populations, will make it very difficult for us to reduce hepatitis C deaths as laid out in these plans, and to reach ultimately elimination goals. And so our hope is that by visualizing these treatment restrictions, health departments, policymakers, researchers, and community leaders will be better able to identify where disparities in outcomes, programs, and resources can be addressed to reverse inequities in access to care and help people to get into care. So I'm going to turn the presentation over at this point to Phil Waters.
Thank you, Heather, and thanks to the entire HepView team for integrating our data into the existing data visualization tools and giving us this spot to highlight the work that we've been doing and how people can get involved using these new tools. So I'm Phil Waters, a staff attorney at the Center for Health Law and Policy Innovation at Harvard Law School, and our mission is to advocate for legal, regulatory, and policy reforms that improve the health of underserved populations, with a particular focus on people living with hepatitis C and HIV. So I wanted to start off by giving everybody a bit of a history lesson, if you will, to broaden our perspective as to how this project even came about, and to show you all how the landscape has evolved for hepatitis C treatment access in about the last decade or so. So our history lesson starts off in 2013 when the first commercial direct-acting antivirals came to market with the introduction of Sovaldi, and then shortly after Harvoni in 2014. At the time, I'm sure you, if you were around, you remember the news headlines talking about the launch prices being astronomically high, with a single course of treatment being around $84,000 for the standard 12-week regimen, or about $1,000 a day per pill. And so, of course, this high price led many payers to impose restrictions on access to treatment. And at that time, we just knew people were having trouble accessing it, but few people really knew what was going on apart from the providers on the ground. So in 2014, our faculty director, Professor Greenwald, along with Dr. Lynn Taylor and other researchers from the Kirby Institute at UNSW, conducted a review of Medicaid reimbursement protocols for, at the time, just Sovaldi, and found that treatment access restrictions were common and frequent, but that the transparency in that information was still really severely lacking. And this review of information was published in the Annals of Internal Medicine in 2015, citing that information from around December of 2014. Advocates, including CHILPI, as well as the National Viral Hepatitis Roundtable, then took this preliminary information to the federal government to let them know that this was happening across states. in state Medicaid programs. And as a result of this collective advocacy, the Centers for Medicare and Medicaid Services, the federal agency that oversees the program, issued guidance to all state Medicaid programs, reminding them of their obligation under the law to cover all medically necessary hepatitis C treatments without restrictions that are non-medically indicated. And there they specifically cited two fibrosis, sobriety, and prescriber restrictions as examples of some non-medically indicated restrictions that violate federal Medicaid law. After that, I'll say we were kind of naive and thought we had solved the issue. But unfortunately, despite that guidance, states kept doing what they were doing, imposing these restrictions, and CMS really wasn't interested at the time in taking any further action. So being a lawyer, when policy advocacy doesn't work, you sue people. So in 2016, Chilpy, along with the Columbia Legal Services and a local law firm, filed a class action lawsuit against the Washington State Healthcare Authority in Federal District Court in Seattle. This lawsuit challenged the Washington Healthcare Authority's policy of rationing their Medicaid coverage of direct-acting antivirals to those with only F3 or F4 level of fibrosis. This lawsuit was successful in forcing the state to provide medically necessary DAAs to eligible individuals and paved the way for many other successful class action lawsuits and settlements in other states. In 2017, we realized that the information on access to Medicaid treatment for hepatitis C was still incomplete. And after the lawsuit, there was a lot of hunger for the information in the community from people that wanted to sue their own state Medicaid programs. And so Chilpy and NVHR collaborated together and launched the State of Hep C to detail the 3 Medicaid treatments restrictions that Heather previewed for you all earlier. And from 2017 to now is what I'd like to talk about next and highlight some of the trends that we've been seeing with our collective advocacy using the tools available at stateofhepc.org and now available on HepView as well. So next slide. A bit of methodology first before we look at the results. So our data since 2017 documents the current state of Hep C treatment access policies, specifically in the fee-for-service Medicaid program. I'll note that our state-specific report cards available on stateofhepc.org provide information about the managed care organizations operating in the state as well. But because of the way the law is structured, managed care organizations are supposed to follow the fee-for-service policy or at least not be as more restrictive. So knowing the state's official policy via fee-for-service is key to our advocacy. To source all this information, we chose to rely on only publicly available information. We did initially conduct a survey of state Medicaid officials, but often found that this was incomplete and unreliable. And furthermore, transparency of these policies is critically important for both physicians and for advocates. So we chose to put ourselves in the lens of a Medicaid provider or a patient that was looking for this information, and we only collected stuff that was accessible to them, including publicly available documents like prior authorization forms, clinical treatment criteria, as well as any other official press or media releases mentioning hepatitis C treatment access restrictions and any changes to them. And so since 2017, we've periodically updated this information in snapshot format so that we can track what's been happening over the years with these restrictions up to today with our latest progress report. So Heather briefly went over this, but just to provide a little bit more detail about the 3 restrictions that we track. So first off, fibrosis refers to the amount of damage Hep C has done to an individual's liver, measured on a scale of 0 to 4, 0 indicating there's no damage to the liver, and 4 indicating liver failure or cirrhosis or extensive liver scarring. So of course, the biggest change we saw after the introduction of DAAs was that Medicaid programs made essentially cutoff levels for fibrosis as a way to limit treatment. So for example, right now in Arkansas, you won't get treatment as a medicated patient unless you are sitting at F3 or above, which is almost at a cirrhotic level. This is essentially telling people with the diagnosis of a deadly infectious disease that they can't get treated until they get sicker. Obviously, this undermines both individual health and public health because these people can continue to transmit the virus to others while they're waiting for treatment. Similarly, sobriety restrictions, as Heather mentioned, require people to prove abstinence from drugs or alcohol before treatment can be approved. A note here that we're specifically looking at periods of abstinence before treatment could be approved. Many states, as Heather mentioned, stipulate patients have to be either screened for drug or alcohol use and referred to a treatment program or abstain while during treatment. And while we think this is also a barrier, For the purposes of this analysis, we thought it was more important to track the delays in treatment attributable to these policies. And obviously these hamper our efforts to stop the spread of hepatitis C because injection drug use is one of the primary ways in which the virus is transmitted. And then finally, a note on prescriber restrictions. As Heather mentioned, this just sort of limits which prescribers are allowed reimbursement authority in the Medicaid program, often limiting it to gastroenterologists, infectious disease physicians, hepatologists, or at least a consult with them. And so this really puts a strain on the system and creates a bottleneck in places like rural areas where there's maybe only 1 or 2 physicians that meet that criteria in the county or even in the entire state. So let's now take a look at each of these restrictions in turn and see how the landscape has evolved from when we started tracking the information in 2017 till today. So in terms of fibrosis restrictions, this is where we've seen the most dramatic improvements in terms of states opening their access over the years. Since 2017, 32 states have eliminated or reduced their fibrosis restrictions, either as a result of litigation, the threat of litigation, or because of the years of collective advocacy by the patient and provider community. To date, only 4 states require documentation of any kind of liver damage to qualify for treatment: Nebraska, Arkansas, South Dakota, and Texas. And we are currently engaged in litigation against the state of Texas and are hopeful that this number will be dropped down to only 3 states by the end of 2021. Unfortunately, sobriety restrictions are the most common limitation that we still see. The good news is that 21 states have loosened their sobriety restrictions since we started off in 2017. And there are now 39 states that don't have any minimum period of abstinence before treatment is approved. Unfortunately, that means that there's still 13 states that mandate some period of sobriety prior to treatment initiation. At a minimum, we've at least seen that the time period required has shortened in states that persist with this restriction. So no state requires still a full year of sobriety, as we saw in 2017 when we first launched, and the average period required is now under 6 months of sobriety. 15 states still require their providers to ask patients about past or current substance use and their treatment status for that. And again, while this clearly isn't as restrictive as a period of sobriety prior to treatment, it still works to deter those that may not be ready or willing to disclose their substance use or to address it. And so finally, turning to prescriber restrictions, since 2017, about half of states have moved their restrictions in a positive direction, and only 18 states today still require some kind of specialist involvement. And only 2 of those, Arkansas and New Jersey, require that the specialist is the actual provider. I think it's additionally a good note to say that we're happy to see, along with removal of this barrier, we're starting to see states step up and offer training programs for primary care providers and other mid-level practitioners that want to learn about how to care for patients living with hepatitis C, helping us to expand sorely needed provider capacity in this area. Next slide. So all these restrictions are fundamentally implemented through a prior authorization protocol where a provider has to obtain a bunch of information from a patient through labs and visits in order to prove to the Medicaid program that they meet the criteria. And as I'm sure you can imagine, and that many of you experience yourselves, this eats up countless hours of clinician time that could and should be better spent actually providing care to patients. Additionally, I don't want to give the impression that the 3 restrictions that we track are the only ways that access to hepatitis C is limited in the Medicaid program. There are a number of other restrictions that live in a state's prior authorization protocols that are not captured by our information. For example, in many states, the Medicaid program's formal policy is that you only get 1 course of hepatitis C treatment per your lifetime. And if you get reinfected after being cleared, tough luck. I personally think that's insane, and that we'd never say something like that to someone that came back with, say, their diabetes uncontrolled after having it controlled. But because we only track those 3 restrictions, we thought it was also worth beginning to track what we see as the gold standard, really, or the floor of providing medically competent care for Hep C in the Medicaid program, with these 7 states now that have removed prior authorization entirely for hepatitis C treatment. So in these states, providers can simply prescribe treatment without the need to complete that burdensome paperwork. In Washington, California, Louisiana, New York, Wisconsin, Indiana, and Michigan, they now all allow access to at least the state's preferred hepatitis C medication that's pangenotypic without requiring any prior authorization. So I hope this has given you a sense of the success that we've had over the years, but also the work that still needs to be done to get to open access and ultimately elimination. I'm going to pass it over now to my colleague, Adrian, who's going to describe some of the ways that you can use our information along with the tools provided by HepView to help us with that moving forward.
Thank you so much, Phil, and thanks for having me today. My name is Adrian Simmons, and I'm the Director of Programs at the National Viral Hepatitis Roundtable, We are a national coalition of patients, providers, community-based organizations, and public health partners, all working together to eliminate viral hepatitis. First, I'd like to commend HepView on their ongoing commitment to visualize data and provide tools that really help advocates push for improved access to hepatitis prevention, treatment, and care. Today, I'm going to be talking about two tools. Next slide, please. And I'll start by talking about how HepView's interactive maps can be used to advocate for removal of treatment access barriers. These maps serve two primary purposes. First, they tell a story that hepatitis C is an ongoing public health crisis and that there are modifiable barriers such as prior authorizations that must be removed to eliminate viral hepatitis. Secondly, these maps make data more accessible. Barring any technological or digital literacy challenges, you don't need to be an epidemiologist or physician in order to interpret these data. Shown here on your screen are maps comparing two data sets. On the left, you'll see hepatitis C related mortality with the dark purple states indicating higher rates of hepatitis C related mortality. On the right-hand side of your screen, you'll see a map detailing sobriety treatment access restrictions, and the darker red states indicate more severe sobriety restrictions, with the lighter red states indicating no or little to no restrictions in place. At a glance, you can see that states who have more severe sobriety restrictions, so those darker red states, also correlate with states that have higher hepatitis C related mortality. This is just one example of the ways in which these maps can be used to really visualize what's happening in a community. Additional data sets are available to make a number of side-by-side comparisons. There's also data sets that detail overdose mortality, which can be compared with sobriety treatment restrictions. There are maps available to detail hepatitis C prevalence, and those could be overlaid with prescriber restrictions or fibrosis restrictions, for instance. And so these tools are really powerful in, again, visualizing data and really painting the picture of hepatitis C treatment access, both locally as well as nationally. Next slide, please. The second tool that I'd like to talk about today are the state profiles that HepView provides. And so each state has a profile that provides a number of different characteristics about hepatitis C in that community. It provides details such as hepatitis C prevalence, hepatitis C mortality, social determinants of health data, and then the newly added treatment access restrictions that will detail what the restrictions are based on the three criteria that you've heard about today. Either the maps or these state profiles can very easily be downloaded and incorporated into various advocacy strategies that you may be using to raise awareness about hepatitis C with policymakers. Next slide, please. And so I'll just spend some time talking through the ways in which you can use this information to engage in advocacy efforts from the perspective of a patient, a provider, and then certainly anyone who is passionate about eliminating hepatitis C in their community. And so starting with the perspective of the patient, the patient voice is the single most important advocacy strategy that we have at our disposal. And so for anyone that's on the call today who has lived experience with hepatitis, please know that your story is the most important story that we can share with policymakers. In the case of treatment access restrictions, sharing your story with state officials such as the Medicaid director, the Secretary of Health, as well as the governor's office can really help policymakers understand how these discriminatory restrictions are impacting your ability to access care. In addition to meeting with specific state officials, it is also very important to engage in public comment opportunities. And so there are two committees on the state level that are responsible for making decisions around treatment access barriers for hepatitis C. And so that's the Pharmacy and Therapeutics Committee and the Drug Utilization Review Board. These are two committees made up of pharmacists and physicians who may or may not be providing hepatitis care to their patients. And so it's very important that we use these committees as an opportunity to raise awareness about these treatment access restrictions and how they're impacting the care that you're able to receive. Similarly, there are many other ways in which you can raise awareness about hepatitis C in the general community. Examples include engaging in state coalitions and supporting any of their awareness and advocacy efforts. And then finally, leveraging media outreach, such as opinion editorials, letters to the editor, and social media to help spread awareness about how these restrictions are impacting you. Next slide, please. The next advocate perspective that I'd like to talk through is that of the clinician. And so there are very similar strategies that you can use here that I've already spoken about from the perspective of a patient, but there are a couple of different additional strategies that I'd like to highlight very briefly. The first is that it is critically important for us to document all of the instances in which patients are unable to access care. Compiling those examples and actually providing those during any public comment opportunity that I've talked about regarding the Pharmacy and Therapeutics Committee or the Drug Utilization Review Board is very important to, again, making sure that we can connect the impact of these treatment access restrictions to a real person. You can also join forces with other clinicians and send a sign-on letter to the state officials that I discussed on the previous slide, or request meetings with them as well. And then finally, again, not underestimating the power of using things like opinion editorials, letters to the editor, and social media to help raise awareness. One last thing that's important for clinicians is not forgetting to use any opportunities to raise awareness about this on the scholarship level. So when you're giving presentations at professional society meetings, if you're considering publishing manuscripts, consider elevating treatment access restrictions and the impact that they've had on your patients within those scholarly activities. Next slide, please. I'll wrap up just by talking a little bit about how you can get involved in advocacy efforts and use this data to support broader advocacy efforts, even if you aren't a person with lived experience or you aren't a person that is providing care in your community. And so to start, you can support federal advocacy efforts led by organizations like TILPI and NVHR, such as calling on CMS and HHS to hold states accountable in removing these discriminatory restrictions. Again, reiterating the importance of actually tracking and documenting any denials or challenges in accessing care, and being sure to engage with organizations like NVHR and TILPI. Having examples is extremely helpful for litigation, which Bill has talked about already, so I won't spend too much time on that. While it's super important for us to hear about the bad news, it's also really important for us to hear about the good news. And so we would encourage you to share information with us about how the removal of restrictions in your community has impacted people being able to access care. And then finally, join the NVHR Voices for HEP network. This is a network of over 200 patient, provider, and community advocates who are interested in taking action in their community. And really, it's an opportunity for us to join forces and allow organizations like NVHR and TILPI the opportunity to help support you in your advocacy efforts. So we need as many voices as possible to continue pushing for equitable access to hepatitis C treatment, and we would love to have you join our efforts. Next slide, please. Just a reminder here, there are a number of infographics that are available to you as part of the launch of the new maps on HepView. And so these can be found on the HepView website. We would encourage you to share them on social media. There are a number of sizes available so that you can share them across social media platforms. But we would appreciate any assistance in getting the word out about these restrictions. So thank you so much. And now I'll turn things over to Heather and Dr. Taylor.
Hi, Dr. Taylor.
Hi, everybody. Hello.
Thanks so much for being here today. We're really looking forward to hearing from you about your experiences in treating people living with hepatitis C and indirectly also about the patient experience. So I want to start with a sort of general question. We know that there are lots of preventable conditions that can happen when hepatitis C treatment is delayed or is not received altogether. But what does delaying care mean for patients in terms of patient health and also in terms of public health?
So delaying care can mean that liver disease progresses, that cirrhosis can develop. Delaying care can mean that liver failure or liver cancer can result. Premature death may occur, and it can be a harrowing death of tremendous suffering and pain. There are extrahepatic or outside the liver complications of Hep C that may develop. For example, mixed cryoglobulinemia, which can cause kidney damage and a very painful rash. Some cancers are associated with hepatitis C. One example is non-Hodgkin's lymphoma. And because of the association of Hep C with certain cancers, some oncology programs now even include a Hep C doc on staff to make Hep C treatment part of certain cancer care plans. But if we treat and cure Hep C early, the complications of the virus can be thwarted. And then of course, there's the emotional toll of harboring Hep C and the stigma and mistreatment that people can face. So you can present to an emergency room with COVID-19 being unable to breathe, and some healthcare worker sees you have Hep C, and maybe assumptions are made. Maybe your pain isn't treated the same way. I've heard a patient say that his dentist always told him, you have to be the last patient of the day. We don't want you infecting anyone. We've heard families say, grandma can't hold the baby, she has Hep C. None of this makes sense scientifically, but it's hurtful and shaming. It's very important when people are cured that the electronic health records, the medical records, are changed from Hep C to history of Hep C. And the last part of your question, what can delaying care mean for public health? Well, the longer we have Hep C flowing in our bloodstream, the longer the time of potential transmission. So we've created a public health crisis in the US as Hep C's continued to spread.
Yeah, absolutely. So you talked a little bit about the sort of emotional toll that hepatitis C can take on patient health. And what about patients that are really motivated to seek treatment, but they're not able to get it because of some of the restrictions we talked about today? And how do you see that impact, patient mental health and even, their motivation to keep up with their engagement in hepatitis C care?
Well, trust and faith in physicians and healthcare workers in medicine can really be eroded. People can feel so discouraged, especially after putting in the time and the effort into a mega workup. People are told, maybe people who don't want to have their blood drawn, don't feel comfortable, have more difficult venous access, and maybe aren't treated in a comfortable way when they're getting the blood work. People have to get lots of blood drawn. Sometimes people are sent to get a liver scan. And then after all this, which can take time, people are told, nope. And so people can drop out of care and may present years later with symptoms and signs of advanced liver disease, fluid in the belly, ascites, variceal bleeds, complications that are traumatic and life-threatening. So I think it's really important on our end that clinicians leave the door open. All of us need to say, look, I'm here for you no matter what. If you drop out of care, if you've missed 10 appointments, if you miss 100 appointments, 1,000 appointments, we'll be here on day 1,001, and you can always come back and call. And as a matter of fact, my nurse partner, Sophie Spreck-Walsh, she's Lucy, I'm Ethel. She spends a lot of her time reaching out to patients again and again to try to help people re-engage who've been really disappointed. And just going back to what Phil said, I think it's critical that we explain to patients why treatment's being denied, because some people think there must be something wrong with me. I use drugs, something's wrong with me, my liver's not sick enough. I explain to all my patients when we face restrictions, there's nothing wrong with you. Let's acknowledge why there are restrictions. It's because pharmaceutical companies have priced the DAAs too high in the United States. So we have these breakthrough meds priced too high so that we cannot meet public health need. Whereas the rest of the world has all decided, let's cap the prices. And as Phil said, it could be $1 a day, $100 a day, while the same pill in the US was $1,000 a day. Because we in this country won't cap the prices, we in the US pay for the rest of the world's successful negotiation. And, I'm not saying it's easy. There's no NIH funding for Hep C. And, we're told don't do Hep C research. It's hard to divest from pharma, but, shame on the NIH. There's no excuse when Hep C before COVID was the leading infectious disease killer in the United States. And the prices have come down, but not enough. And what I explain to patients is, this is what it's about. It's not you. what I really care about with advocacy is getting to some of the money trails. You know, why, for example, in Rhode Island, why were we told for years that insufficient funds existed for Rhode Island Medicaid recipients to get DAs? But meanwhile, look at your Medicaid providers. Our largest Medicaid provider in Rhode Island, Neighborhood Health Plan, scored $1,366,000 in revenue in 2017 as Rhode Island's second fastest growing private company, while they told us we can't pay for DAAs. This is the same for United Healthcare, another provider of Medicaid in Rhode Island. So some states have passed laws to restrain or impose transparency requirements on pharmaceutical prices. I think we need to follow the money, and look at this further.
Mhm. No, absolutely. Those are really complicated and long stories to explain to patients, though. And I'm sure, a lot of people continue to feel like, as you said, something must be wrong with me, and sort of lose interest or motivation in seeking treatment. I think, we've all had the experience of calling and trying to make an appointment with the doctor and being told you need a referral. And even those simple one-step processes can keep people from getting care. And so this is a really difficult. So I want to just switch gears a little bit, and talk about the commentary that you wrote recently for the Rhode Island Medical Journal that got a lot of attention in this hepatitis C world. So your commentary was about the practice of refusing treatment for hepatitis C to people with substance use disorders. And you correctly pointed out that when these patients die, their livers may be donated to people who are not living with a substance use disorder, and then will be treated for hepatitis C at that point after the patient has passed away. So could you just summarize sort of the key points from that commentary, and why this is such an important ethical and moral dilemma?
Sure. First, let me say that I'm a viral hepatitis doc. I'm a big advocate for people getting liver transplantation and getting transplantation overall. I went to Pitt, the birthplace of liver transplantation. So of course I want people who are going to be very sick and die to get organs from people who died in order to save their lives. But what's happened is that in the United States, the rising number and proportion of hepatitis C infected organs from young people who've overdosed are being used for transplantation. So we have a convergence. Both overdose deaths are way on the rise. You've probably heard that we've had the worst year ever in the United States for overdose deaths. Now we also have a rise in Hep C incidence in the United States with the opioid crisis. So now we have a situation where Hep C is increasingly common among organ donors. And with the advent of these all oral regimens, DAs, coinciding with these public health tragedies, what's happened is that we now harvest grafts from Hep C infected overdose victims. It's now all of a sudden this opportunity to expand the donor pool. And these solid organs are good quality because all of a sudden we have all these young people with young organs that are healthy dying who can be organ donors. And what's happened is we have a new acronym. We shouldn't have this acronym, ODD, overdose death donors. Over the past few years, we have almost a 25-fold increase in transplants using organs from overdose death donors. And who is the fastest growing donor category? People who inject drugs. So again, of course, I want people to have their lives saved through access and transportation. And I really understand that when there is an overdose death, it's so agonizing that people can feel better. Hey, at least something good can come out of this. My loved ones' organs can all be donated. But now what has happened with really out much discussion or public awareness is that we're transplanting Hep C infected organs, not only into people who already have Hep C, but into people who don't have Hep C. This is the first time that I've been able to find in the world we intentionally take a virus that's not weakened or attenuated and deliberately infect another person. And then the organ recipient is now getting DAAs after transplantation. Well, meanwhile, the person who overdosed and died and is providing all the organs may not have been able to access DAAs in life because that person faced the restrictions that we've all been talking about. So what about thinking about this from the standpoint of the opioid crisis? To some extent that was created or at least exacerbated by Purdue Pharma, the makers of OxyContin. Where's the preventive care? Where are upstream preventive strategies? If we want to go down this path, how about at the same time investing at least an equal amount into prevention and treating addiction, addressing contributing social and economic forces, and reducing overdoses. And you know what, one thing that prompted me to write this was I was reading an article in the liver transplant literature that said viable kidneys from Hep C infected donors must be treated as a valuable resource and not discarded.
Mm.
And we should put them into people who don't have Hep C and then let those people get DAAs. But people with opioid use disorder, with substance use health problems, must be treated as valuable human beings and not discarded. So we need to do more to get people access to evidence-based treatment for substance use disorder and access methadone and work on decriminalization of substance use. We're incarcerating more people in this country than we're treating for substance use disorder. We don't have adequate syringe access. So that was the real question that I asked. Should a Medicaid recipient deny DAAs due to Medicaid sobriety or other restrictions who overdoses be used as a donor with the recipient getting DAAs? Do we need to examine the ethics of this, or are there financial gains in some places where certainly transplant and procedure-based medicine makes a lot more money? Meanwhile, infectious disease docs are told, don't do Hep C. You're not meeting your relative value units. You're not bringing in enough money.
Yeah, I mean, I think that commentary gave a lot of people pause, in thinking about these sobriety restrictions in a new way. Even those of us who, of course, are against these restrictions in the first place. So one last question for you, and this is a big one. What messages do you have for us on the call for advocates, other providers, and patients in terms of what we can do to help reduce and eliminate these treatment restrictions, and ultimately to eliminate hepatitis C, which is the goal for all of us?
Okay, so 4 points. So Phil was talking about the history. I think history is everything, and I spend a lot of time reading the medical literature. This year marks the 20th anniversary of Dr. Brian Edlund's New England Journal of Medicine article, "Is it justifiable to withhold treatment for Hep C from people who use drugs?" I urge you to go back to New England Journal of Medicine 2021 and read this short manuscript. Yes, it was written in the interferon era. It is somewhat dated with respect to language, but Dr. Edlund makes many of the key arguments against restricting treatment access that hold today. There's no rationale for the restrictions. They're not based on evidence. They're not consistent with policies for other similar conditions. Substitute cancer, and none of this would apply, as we've heard. Wait until the cancer advanced, you'd lose your license. You're not worthy of cancer treatment if you use drugs, you'd lose your license. If poor adherence were contraindication to medical therapy, hypertension, diabetes, asthma would never be treated. But when it comes to this one infection, this has been allowed to continue. And I would say, again, enough already. It's got to stop now. We're stuck in a Hep C Groundhog Day. You've seen that Bill Murray movie, Groundhog Day. We're in a Hep C Groundhog Day. We've been making the same arguments for over 20 years, while more people are getting infected in this country and more people are getting sick, while other nations are on their way towards elimination. So we've heard today we're 8 years into the DAAs. Bill was saying it was December 2013 when we had the ability for all oral therapy. We're way beyond negotiation. It's 8 years into this. So again, pre-COVID, Hep C had become the biggest infectious disease killer in the United States. So it's time for definitive action. And I'm really grateful to Kevin Costello and Robert Greenwald and Phil and their colleagues, because we had to instigate a lawsuit. So that was my longest point. My second point is prevention. As mentioned, with no NIH funding earmarked for Hep C research, the research field is funded and shaped by pharma. Let's be frank here. Advocacy is in part funded by pharma, way beyond what we've seen for HIV research or advocacy. So I don't know that we can all right now have perfect insight into the ways in which the Hep C field may have been or is currently being impacted by this. And one effect is the pharmaceuticalization of the field. That's a long word, but we need treatment, yes. We need DA access, yes, but we need prevention. In the absence of a Hep C vaccine, we need methadone access. We need buprenorphine access. We only have 1,500 methadone programs in the US. We need syringe access. Syringe service programs are illegal in 11 states. We need one brand new syringe for each injection, not you bring one in, you get one back. We need evidence-based treatment for substance use disorder, not you go somewhere where there's no medical approach. We need research and better treatment for stimulant use disorders. So prevention. The third point, no more candidacy. Respectfully stop anybody who talks about candidacy. There's no such thing, unless you're from another planet. If you're human, you're a candidate. There's only one medical exception to candidacy with Hep C treatment. And you can see this in the society guidelines for the American Association for the Study of Liver Diseases. It's universal treatment unless someone has a very short life expectancy, say 6 months or less, that cannot be remediated by DAAs. So let's stop focusing on patient and individual level barriers, and let's optimize systems to overcome these. I think candidacy is quite arrogant. So me as a doctor, I get to know a patient in some aspects, and then I get to decide whether that person meets a definition of candidacy. So let's never hear that word again in the Hep C field. And finally, for those of you not involved or who haven't heard of INSHU, look to INSHU. This is the International Network on Health and Hepatitis in Substance Users. INSHU is a global network dedicated to improving the health of people who use drugs, with a specific focus on hepatitis C, infectious diseases, and harms that can occur from drug use. So we got to get our heads out of the proverbial US sand and look and see what the rest of the world is doing, because the rest of the world is doing a lot better. Switzerland, Australia, Portugal, Iceland, Egypt. We don't need to reinvent the wheel. No, Australia already has finger prick RNA diagnosis, and then 2 minutes later you start your Hep C treatment, test to treat. I just copy them. I'm not that smart. I look at what they're doing. Switzerland, years ago, I mean, they prescribe heroin to patients. They have co-located care. Wherever patients can access care, you go there and you treat. That's why I provide care now outside the tertiary care center. The INSHU conference this year is in Australia, but you can participate virtually and it's very reasonably priced. There are scholarships and there are lower rates for people in the community, nurses, et cetera. And we have a lot to learn from our international collaborators and colleagues and friends.
Absolutely. I can say I personally attended that conference for the first time just before the pandemic and learned so much. So highly recommend. Thank you so much. So I think we're at time for a few questions and answers. And if I could just ask each of the panelists to come back on camera. Thank you. So if you all could just type any questions that you have in the Q&A box, I'll moderate them to our panelists here. And the first question that I see here is for you, Phil. You mentioned in your talk addressing Texas and its fibrosis restrictions. So what other steps are Chilpy and NVHR taking to reduce restrictions in other states?
Great question. A few things I'd like to mention. It's not in the Medicaid side, but in terms of other active litigation, we also have an ongoing lawsuit with the Vermont Department of Corrections for their treatment access restrictions, because similar restrictions persist in the correctional space. Another big thing that we are working on this year is that we have been in discussions with the Department of Justice to ask them to enforce the Americans with Disabilities Act against states that continue to impose sobriety restrictions. So this is based off some research that we published last year in public health reports that I'm dropping a link to the chat to our press release if folks would like more information about that theory. And then I'll let Adrian maybe talk about some of the more patient and provider advocacy that's going on in the states that we're using this information with.
Thanks, Phil. And I think that this will segue nicely into the second question that we got that was directed towards me, which is kind of what are the best tools that we can use to help remove some of these restrictions. And so the number one answer is always engaging people with lived experience in these discussions. Again, they are the single most important voice that we can bring to this discussion. And so making sure that we are centering them and engaging them in all of our advocacy efforts is critically important. The other thing that I think is underestimated and not well understood by many people is how these decisions are made at the state level. And so it really requires you getting to know your state government structures and who are the committees that are making these decisions, and then who are the players that make up those committees. And so it may be in one state, it might be the Pharmacy and Therapeutics Committee. In another state, it might be the Drug Utilization Review Board that's making these prior authorization decisions. And so it's really important to know who you should actually be directing your efforts to. And those committee structures, again, vary by state. Similarly, the folks that make up those committees are just everyday physicians and pharmacists. And so it's likely that you may even know some of the folks that are on that committee. And so building relationships with them, again, making sure that you're raising awareness and educating them about how these restrictions are impacting your community is critically important. But I do think that we have a long ways to go in terms of getting more patients as well as providers engaged with those committees on the state level.
Super. So anyone who still has a question, we have just a few more minutes. If you want to type it right in the Q&A box, I'm happy to ask it. I guess while we're waiting to see if anyone else has final questions, I'll say we recently did an expert Q&A blog with Dr. Leslie Miller, who's here in Atlanta. Yeah, we all love Leslie Miller. So about, her experience treating hepatitis C patients and fighting these restrictions. And so this question, Lynn, is for you and for others, Adrienne or Phil, who might want to chime in. What are there sort of creative solutions that providers out there who may be looking for creative solutions to deal with treatment restrictions can use in their own practices beyond advocacy and the ultimate goal of getting the restrictions removed?
So, for 4 years, and I don't mean once a year, I meant every day, we tried really creative solutions. So we met, and Rhode Island's a tiny state. We all work together. We are all collaborating. We're all interconnected. So, we were talking to everyone from the governor to the health department, the department of, there's nobody that we didn't meet with and didn't talk to. Medicaid, everybody, meeting, discussions. It was always about the money.
Mm-hmm.
And I tried to bring in outside experts. I put on big conferences because in a tiny state, the one person talking, they'd say, oh, there's a Lynn doctor again, always yakking about Hep C. So, that voice we've heard, we need other voices, lived experience voices. I said, I better get out of this picture. So I put on all these Hep C conferences, and because of the graciousness and generosity of Hep C experts all over the nation, we had Dr. Brian Edlin, Dr. Ann Spalding, Dr. Ray Chung. We had national experts come out of the goodness of their hearts, their busy schedules, to 2 big statewide conferences, as big as you can be in the tiniest state, and spoke to raise consciousness where, those of us who kept speaking out would be more in the background. We did all of that. Then I put on some of the biggest festivals in the world for Hep C. Every summer on World Hepatitis Day, Hep C Water Fire, this huge festival with tens of thousands of people, raise awareness. And we brought in the head of Hep C at NIH, Jack Kalsa, and Dr. Edlin. We brought in the head of the CDC, the older head of the CDC. We would bring in all these national figures, have meetings, hoping in a way to kind of shame Rhode Island Medicaid into doing something. And they'd say, we want to, we're going to. They would meet with Dr. Kalsa, they'd meet with the CDC, they'd meet with all these people, national leaders, and then nothing would happen. So after all of that, after all those negotiations and all of that, then finally, it was at INSHU that I heard Bill's colleague, Kevin Costello, speak. And he said, if you need help, call me. So I was also at Brown, and I was told, you can't be at our tiny state and academic medical center and be suing Medicaid. So my last day I'd resigned was January 31st, 2018. And February 1st, 2018, I called Kevin Costello, said, we got to do this, because we've tried every type of negotiation and creative event. The meetings Adrienne talks about, we went to the meetings with the pharmacy benefits managers, and then they wouldn't let us go. We were blocked from going. So I used to have med students go, and they're not experts in the field, and even they're very knowledgeable people. So one of the meetings, when the med students take notes, they spent the whole half hour devoted to Hep C deciding what's a retrovirus, what's treatment for a retrovirus versus treatment for a virus. And as Hep C, it was at that level. There were so many big decisions being made without a lot of knowledge. So after all of that, enough already. It was getting to the point, and you'll hear from one of the patients, we saw patients getting sicker and sicker, people dying, more. I couldn't keep up. Sophie, my partner, and I, my nurse partner, Sophie Speck-Walsh, and I, we just seeing the new cases coming in, new, and we couldn't keep up with the new cases, new infections. We finally just said, and I told the governor, I told the head of the health department, I told them all, I'm really sorry, but we're instigating a lawsuit. And then things got better.
Yeah. Wow, that's a really powerful story around an unfortunate step that had to be taken. So we are at time now, and I just want to thank you all again for being with us. This has been great. I always learn a lot myself on these webinars, and just love to hear about the issues that we present data on from multiple perspectives. I think it really helps to make the data visualizations meaningful across different groups of people. I would encourage you all to please go and check out the new treatment restriction maps on hepview.org. And also please check out the new expert Q&A blogs. We also were fortunate to do an expert Q&A blog with one of Dr. Taylor's patients who really speaks about the impact that all of the advocacy that she and others have done has had on his own life. And so I think that, hearing from the patient perspective really makes it hit home the importance of this work. So thank you, everybody. And we look forward to having you back at HepView again.